In the last chapter, we're going to talk about insomnia. Insomnia is a symptom, and it's very, very common. 35% of the population complain about insomnia at some time in a given year. There are certain risk groups: women, older adults, postmenopausal women, shift workers, patients with pretty much any kind of chronic medical or psychiatric disorder. One of the most common causes of insomnia in adolescents is delayed sleep phase syndrome. And this is defined as persistent, greater than 6 months, of the inability to fall asleep and arise at conventional clock times. So what happens to these adolescents? They're in high school, and they have to get up early to go to high school, and they try to go to bed at midnight. But they can't fall asleep. They can't fall asleep until 3 or 4 in the morning, and they have to get up at 6:30, 7 to get to school, and that becomes problematic. If you let them sleep in, they're fine. But they often develop sleep onset insomnia because the parents will say, you need to go to bed. They try to go to sleep. At midnight, they can't fall asleep till 3 in the morning, and they wake up and they're tired. If they work on a different pattern, if they're homeschooled or if they're in an occupation where they don't have to get up early, they do fine. So typically these patients will have some type of shift work. They'll maybe work the 3 p.m. to 11 p.m. shift, and they're fine. But if you make them come in at 8 in the morning, it's very problematic. Their sleep, if you let them sleep, is normal in pattern and duration, but it's off-shifted. How do you treat it? You can do a number of different things. Bright light therapy, as soon as they wake up, may help. You can try melatonin. What I've used mostly is chronotherapy, where you systematically delay their sleep each night. You can't ask them to go to bed earlier. It will not work. But you can ask them to go to bed later. And if you systematically do that, you can recycle them to a normal sleep time. The problem with that is that they have to maintain that sleep time, and that can be difficult, especially in younger adults. Sleep disorders can come as insomnia. So in 10% of patients with sleep apnea, they'll have insomnia. Restless leg syndrome in particular causes insomnia, not so much periodic limb movements, and we just discussed circadian rhythm disorders. Certain agents, caffeine, which has an 8 to 12 hour half-life, if you take it before sleep, can disturb your sleep and can make it more difficult to fall asleep. There are a number of different over-the-counter medications that have caffeine in them. One example is Excedrin, so you might want to ask about that. Steroids, beta-adrenergic agents, some antidepressants are activating. They can all worsen insomnia. Smoking also makes insomnia more problematic. There's a number of different energy drinks out there. These are just some of the different Red Bulls and different ones. They all basically have caffeine in them. And if the patients or individuals are drinking these after dinner, it's going to cause insomnia or make it more difficult for them to fall asleep. As I already discussed, any chronic disease will cause insomnia. Chronic pain, chronic reflux, patients with renal failure, chronic lung disease where they have trouble breathing at night, heart failure, Parkinson's disease, Alzheimer's, all can cause insomnia. A number of different psychiatric disorders, depression, anxiety, panic disorders, also all can present with insomnia and worsen insomnia. What I typically see are patients with psychophysiologic insomnia. These don't have chronic diseases, but they just have probably a genetic tendency to insomnia, and they've had it a long time. Insomnia is often untreated, and unfortunately, the treatment is often alcohol, which will put you to sleep but then disturb your sleep. So alcohol is a very bad choice. In addition, at least in the United States, there's a number of different over-the-counter sleep aids which are almost all based on Benadryl, which again is a really bad choice because it has a very long half-life. Cognitive behavioral treatment is probably my treatment of choice right now. It's better than pharmacotherapy because it doesn't have any side effects, and it's been shown to work as well as pharmacotherapy. If you do have to use a hypnotic, what is the best one? As I already discussed, alcohol is a bad choice. It causes significant sleep fragmentation. Benadryl, a bad choice. There's very little sleep data. It has anticholinergic effects. It's got a long half-life. Not a good option. Restoril is fine, but all these benzodiazepines will reduce stage 3 sleep for stage 2 sleep, so that's not ideal. There's very little data on aspirin and Tylenol, but if the patient has chronic pain, it may make some sense. Ambien, Sonata, Lunesta, they're all newer agents. They don't disturb your sleep architecture. I like Sonata the best because it has a very short half-life. All of these agents, though, can cause sleepwalking, cause memory effects, and can cause falls at night, which are really problematic. Trazodone may be the agent that's used more than any other agent for insomnia, but again, there's very little data. Romaltion or Rosarum is a works on your circadian systems. Doesn't work all that well, but at least it doesn't have some of the same side effects that Ambien, Sonata, and Lunesta have. There's very few head-to-head trials. It's hard to know what is the best agent if you're going to use an agent, but the bottom line is if you can do cognitive behavioral therapy and they don't need to be on a pharmacotherapy, that would be better. Just to review Ambien, 5 to 10 milligrams, reduce it in the elderly. It does preserve stage 3 sleep. It's got about a half-life of 2.5 hours. Dizziness, next day drowsiness, this night eating syndrome, sleepwalking are all side effects. Sonata I do like. It's got a very short half-life. Again, headache may be a complication, side effect. Do not use it with alcohol. It's particularly useful if someone wakes up in the middle of the night and has 3 or 4 hours still to sleep. If you give it to patients before they go to bed, they may wake up from it. But I do like it because it's got a short half-life and shouldn't have any next day effects. Lunesta, it's got a little longer half-life, 5 to 7 hours. Again, has been shown to be effective in randomized controlled trials for insomnia. 20% of these patients develop a metallic taste. Most of them don't mind it, but some of them do. Rosarum, again, it's a melatonin receptor agonist, works on the circadian system. It can take a long time to work. It's not controlled. Typically 8 milligrams, take it 30 minutes before bedtime. Most common side effect is dizziness and fatigue. It is approved for long-term use. Be careful with severe hepatic impairment. It is relatively safe, but in my experience, it doesn't work that well. You do need to give it a chance, though. If you give someone Rosarum, it will not help them on night number 1. It may not help them on night number 2. It may not help them on night number 10. But you need to give it about a month to see if it actually has an effect. There is a sublingual formulation of Ambien. It's relatively new. I've never tried it, but if you wake up in the middle of the night and you wanted to try a sublingual tablet, it's available. I'm not sure you actually need to do this, but it is available. One of the issues with Ambien and every one of these sleeping pills is that they can reduce balance and potentially make you fall. And the question is that true in hospitalized patients? Is it true in patients at home? And this was a study where they basically looked at fall risk. And what they looked for were adult patients who were prescribed Ambien through electronic medical records. And then they looked at fall rate in those patients with Ambien versus those only prescribed but not administered Ambien. So it was this pretty similar group. It was a group with insomnia. And they looked at the group who actually received Ambien and those who did not. And what they found was that the fall rate was significantly greater among patients who were prescribed but did Ambien versus those who were prescribed Ambien but didn't receive it. And this is what I really worry about. I worry about with hypnotics, the patient gets started on them, they are on them for a long term, they eventually fall or potentially fall, they break a hip, and then it's a real problem. So I think you have to be careful about using hypnotics. And it's become a big issue. And I don't think it's just Ambien that will do this. I think there's all hypnotics and all sedatives. You have to be really worried about fall risk. So in summary, we need at least 78 hours of sleep a night. It's very important to prevent sleep deprivation for obvious reasons. In terms of your patients, ask all your patients about daytime sleepiness, snoring, and other symptoms of sleep apnea. Treatment of sleep apnea can help prevent the cardiovascular consequences that are associated with sleep apnea and daytime sleepiness, including crash risk. If you have a lot of PLMs and they're associated with arousals and daytime sleepiness, treat it. And if the patient has narcolepsy, you're going to want to treat their daytime sleepiness. The primary treatment for insomnia should be cognitive behavioral therapy, not hypnotics. Thank you.